Hi, welcome to NurseEdScholar. So, if I showed you an ABG that said respiratory acidosis, could you picture what the patient actually looks like? Because the NCLEX doesn't stop at the numbers. It wants to know if you can recognize what's happening to the patient in real life. So, in this lesson, I'm going to connect the ABGs that we talked about in the previous video when we were interpreting the ABGs. I'm going to connect that to the clinical signs, symptoms, and reasons in this video. So the numbers hopefully will make sense. All right, let's begin. So on the NCLEX, ABG questions don't live in isolation, right? They're paired with, assessment findings, vital signs, mental status changes, priority decisions. So if you know the pattern, but don't know what the patient looks like, you'll probably still miss the question. And so this video hopefully will help fix it. Now, in respiratory acidosis, the patient can't blow off the CO2. And so when you're looking at the ABG, it's going to show a low pH, which lets you know that the patient is acidic. It's going to have a high CO2 because they're retaining that carbon dioxide. And so this is going to tell you that the lungs are failing to ventilate. And what you're going to see is that the patient is going to have slow and shallow breathing. You're going to see hypoventilation, fatigue, headache, um, some confusion or decreased level of consciousness, and the patient may be warm or have flushed skin. So when the CO2 starts to build up, it actually causes vasodilation in the brain, and that's leading to that mental status change. Okay. So why is this happening? CO2 is an acid. If you remember on my last video, I said that CO2 plus water creates carbonic acid. So that's where the acid is coming from, when we say that CO2 is acid. And when patients retain CO2, they can't breathe deeply or effectively, or they have an airway obstruction or respiratory muscle fatigue. That acid is going to start building up. And so common causes that you're going to see on the NCLEX will be patients who have COPD, um, patients with an opioid overdose, those with severe asthma, neuromuscular weakness, or central nervous system depression. So remember that respiratory acidosis is really dangerous. The CO2 continues to rise, the oxygenation or the oxygen status is going to start falling, and compensation can fail. And like I said previously before in another video, you know, compensation doesn't matter if you can't oxygenate, right? So the biggest thing with these patients is assessing the airway and ventilation because that's the priority. Now, with respiratory alkalosis, the patient is blowing off too much CO2. They're just breathing away. So the ABG is going to show a high pH, letting you know that the patient is alkalotic. They're going to have a low CO2. And this is going to be telling you that the patient is hyperventilating. They are just puffing away. And so what you'll see on your patient who has respiratory alkalosis is rapid breathing, anxiety or panic, which makes you breathe rapidly, lightheadedness, tingling in the fingers and around the mouth, and even chest tightness. Because low carbon dioxide causes vasoconstriction, which leads to dizziness and paresthesias. Now, why does this happen? So on the NCLEX, you'll see causes like anxiety and panic attacks. Pain. Sometimes patients with pain, they have a tendency of breathing rapidly. Fever, early hypoxia, mechanical overventilation. This is often early and reversible, which is why the NCLEX may actually test reassurance or treating the cause. Realize with respiratory alkalosis that if a patient is anxious, tachypnic, and dizzy, think respiratory alkalosis. Now, moving on to metabolic acidosis, the body is producing or retaining too much acid. And what the ABG is going to show you is a low pH and a low bicarbonate. And this is going to tell you that the kidneys or the metabolism are involved, so the kidneys are involved. And the patient is going to present with deep and rapid breathing, also called Kussmaul's respirations. They're going to have fatigue, nausea or vomiting, hypotension, and confusion. Remember, the lungs will compensate by trying to blow off CO2 to raise the pH. Now, why is this happening? In metabolic acidosis, common causes that you'll see on the NCLEX is diabetic ketoacidosis, renal failure, severe diarrhea, lactic acidosis, and sepsis. The body is either producing too much acid or losing bicarbonate. So, remember, metabolic acidosis can quickly become life-threatening if compensation fails. So when you're with your patient, you're going to have to assess their respiratory effort, hemodynamics, and, the causes of acidosis. And lastly, with metabolic alkalosis, the body has lost acid or gained base. So when you're looking at the ABG, you're going to see a high pH and a high bicarbonate. And your patient is going to exhibit weakness, muscle cramps, hypoventilation, dizziness, and cardiac dysrhythmias. You know, Remember, with metabolic alkalosis, the lungs are going to try to compensate by slowly breathing to try to retain that CO2. So, why does this happen? Well, the NCLEX will test on causes like prolonged vomiting, um, excessive diuretic use, NG suctioning, acid overdose or overuse. Um, so there's going to be a loss of stomach acid, which increases alkalinity. So try to remember if the patient has vomiting, they're using diuretics, and they have muscle weakness, then more than likely they will develop metabolic alkalosis. So when you try to put this all together, this is what you're going to have to remember. Respiratory problems are breathing problems. Metabolic problems are systemic. You'll see systemic symptoms. When a person has acidosis, they'll exhibit fatigue and confusion. If they have alkalosis, they'll exhibit irritability, tingling, and muscle weakness. The ABG is telling you what's happening inside the body, and the patient is going to show you what's happening on the outside. And so that's it. If ABGs hopefully finally, you feel connected, with the ABG and connecting it with a real patient, that really was my goal in this video. I just want to try to put that together. So in the next lesson, I'm going to combine labs and medications and fluids. So you'll learn how to decide when orders are actually unsafe for your patient. So please subscribe so you don't miss it, and download the workbook at NurseEdScholar.com when it's released. I always say at the end, my goal is to help you study smarter so you can really test like a pro. And so until next time, happy studying from NurseEdScholar.